this simple case. As I said to Emmanuel, I don't have complex cases, but I think it will be full of enseignement. So I want also to congratulate Professor Abdul Khan, but I know that he's not here, he's in the plane. Congratulate also Professor Maburi and then Sherif Mboub, I don't know if he's here, for the whole Senegalese heart team for their first TAVI case success implantations. So
yeah, that was very great.
Yeah, I hope he was here to have my congratulations, but I think
Exactly.
So our case of today is a simple case of our daily practice. So she's a 57 years old woman, West African woman, hypertensive, diabetes mellitus, well controlled, no prior coronary artery disease or revascularization. So she's referred to our center for coronary PCI 1 week after anterobasal myocardial fraction without revascularization. So she presents severe angina despite optical medical therapy. So angina class 3, and she was hemodynamically stable. All the findings are good. She's a small woman with body mass index, as you see, 27, but 1 meter 59 centimeter. So the EKG shows sinus rhythm, 75 beats per minute, inverted T waves in anterobasal leads, a marked regression of the ST elevation and RS pattern, so no Q, RS pattern in the inferior and basal leads. Echocardiography shows inferolateral and inferior hypokinesia, moderate left ventricular dysfunction, EF 44%, and the global longitudinal strain minus 13%. So the laboratory findings, the troponin is still higher, but the other findings are within normal range. So here is her current medication. So given the persistent ischemic symptoms and objective myocardial involvement, we proceeded to coronary angiography. So we go by radial access, as you know, and GL 3.5 diagnostic catheter. We see clearly in this caudal view the occlusion of distal segment of the OM, as well as a significant stenosis of the proximal LAD, well seen in this cranial view. We have also a diffuse stenosis of a small non-dominant right coronary artery. So the conclusion is several multivessel coronary artery disease with the LAD, the occlusion of the acute, of the marginal, of the OM, and intermediate syntax score. So we decide to go for PCI of the culprit lesion. So,
sorry, doctor, do you mind if we interrupt and just ask some additional background information before going on to the PCI?
Okay.
Thank you so much. I appreciate it. It just helps set the stage. It sounds like the acute MI was uncomplicated. That was about a week ago. Do you know if she received thrombolytics at the time?
No thrombolysis. Yes,
no.
She didn't have thrombolysis. Yes, I think I noticed in the slide. No thrombolysis, just management by medical therapy.
Okay, and so that involved just hospitalization for a few days and maybe some heparin. Is that correct?
Yes, just heparin and yes. So
okay.
No thrombolysis and no invasive treatment.
Can you give us just a small sense of your the current state of affairs where you are? Do most patients with MI get thrombolysis? If so, what type? And do they come in routinely for angio and PCI after, or only for refractory symptoms? Just some of the logistics where you are.
Actually, this patient lived in a remote area. She lived 600 kilometers from the capital city, Niamey. So for most of the patient, it is the same case. They come generally with delayed presentation, 4, 5, or 7 days, sometimes more after the myocardial infarction. So we have few centers in the peripheral area which have thrombolysis, but most of them doesn't have thrombolysis.
Sounds good. And I see she is on standard background medical therapy. Is there, I was just curious if anything is done differently in these patients who do not get thrombolysis. Do they get oral anticoagulation or something sort of out of the ordinary until perhaps they make it to the cath lab?
So in the daily practice, I think doctors or cardiologists in the peripheral area, they manage just with aspirin, clopidogrel, and the medication that you have seen, and then this medication that you have seen, and the heparin. So she was in hospitalization for maybe a few days before she came to our cath lab.
Okay, thank you very much. Does anybody also have, yeah, it looks like somebody else's hand is up.
Hello, guys.
Hello.
Hello, Ibrahim. It's Professor Boop from Dakar.
Welcome. Welcome.
Thank you. Okay. I just want to have two questions. First of all, the PCI, it is ad hoc PCI. And did you think about looking for viability? And in case of that, what kind of test do you use in your daily practice? Thank you very much.
Thank you. Yes, this is an excellent question. So when she comes, I say she was really symptomatic, severe angina, class 3, and we have seen the myocardial involvement, the troponin are really high. So we decided to go for the PCI. So it is really a good question, but I think in this case, when the patient is really symptomatic, we decided to go for the PCI.
Okay, thank you very much.
Okay, thank you, everyone. So this is, I don't know if you have any comment. This is, so we go with the PCI, with guiding catheter EBU 3.5 catheter. We try to cross with run-through workhorse wire, which failed. And then we will be able to cross with a PT2 MS wire. So we perform several predilatations with a 2.5 balloon. That's 16 atmosphere. And here is the result after predilatations. So I don't know, my dear colleagues, if you have what can be your strategy here. Are you going to put one stent just to stent distally, or you can go proximally?
Hello, Ibrahim, again. Before answering your question, just a few. You put 2 wires before predilatation, or you do predilatation, and after you see that there is a distal 6 circumflex wire very big, and you put second wire or not? Just a little question.
Yes, I tried to cross with the first wire. I tried to cross with the run-through wire. So the run-through wire failed to cross.
Okay.
So I take a PT2 MS wire.
Okay.
So after the PT2 MS wire, when the PT2 MS wire cross, so I put the run-through in the LCX, and I leave it there.
Okay.
Yeah, that's all. And then I perform the post-dilatations.
Okay, when we see after the dilatation, we see that you have a bifurcation,
Yes.
and what is and the two the two branch are very important, and you need to never lose any of these branch. And when we look at to the distal, the distal circumflex, and they have a tight, it is maybe less bigger, but they are severe lesion there. And you can go with provisional stenting, but
Maybe,
you
yes.
need to be sure that when you put your stent to the second marginal, probably you will lose maybe the distal circumflex. And I think that maybe it's better to go ever you do provisional stenting, maybe you put the stent to the distal circumflex, and I think that it will be more easier to go after to go to the marginal and to open the stress and able to look if needed to put a second stent. If you, but even you can go directly to double stent. But I think it will be me. I will put the stent to the distal circumflex and to put a kissing and have to look to the distal marginal and the circumflex, what it look like, and if needed, I put a second stent. But in my daily practice, I don't like two stent strategy, and I ever go to upfront every day upfront to stent strategy, not at my beginning.
Exactly. So thank
Can
you
I
for
comment as well? Just yeah, great comments. Clearly, this is very diffuse disease, diabetic type disease, and you can almost argue the disease starts all the way from the proximal circ and goes down. So you have multiple branches. And yes, there is definitely a risk of losing a number of these branches if we try to treat everything. I do like the idea of the second wire in the distal circumflex. It is a good branch. And I might not do a two-stent strategy up front, but I will balloon the origin of this distal circumflex. That just increases the lumen and then helps keep it open when I bring in the stent. And I think my stent will be from the circumflex into the OM, since that is, to me, that seems to be the larger vessel and the primary site of infarct. But these are all very relevant questions for bifurcations. Do you do a provisional approach? Do you take two stents, which is obviously longer and more complicated? The risk of loss. But I think with this vessel, if it's adequately pre-dilated, the origin especially, then I think it should stay open even after stenting into the OM.
Dr. Tayo, do you use any drug-coated balloons? Or I'm not sure whether if FDA has approved it in the US. But what do you think about drug-coated balloons for that sec instead of leaving it?
Yes, I mean, I think it's a reasonable consideration. Now, the drug-coated balloon is no different than any other balloon in just keeping an artery open.
Yeah.
I think the only question is whether you want to prevent long-term restenosis. And then, yes, at the end, maybe a drug-coated balloon for your final kiss may be helpful there. But I think at this stage, I think any balloon just to open up that branch some more, then you stent across. We'll see what things look like. Kiss, and then if it's very important then to prevent restenosis in that side branch, I think a drug-coated balloon can be considered.
Thank you. So that's what we do. We decided to do provisional stenting. So we go with, we take the whole part from the proximal part to the distal part. So we take.
Okay, I think my contribution here, I also think, Dr. Tayo.
Yes, we can hear you.
Yes, Dr. Ibrahim. So what I was saying is that, in this part of the world, we don't have IVOS. I don't know whether you have IVOS in Miami. We don't have in Nigeria yet. If it was, you could have used it also to look at it to see what is the nature of the plaque, visualizing it, because this is more like a diffuse as a diffuse arterioma that flows around the vessel. So the issue here is we must be careful with the number of stents we put here, because we don't know. Did you give nitroglycerin to see whether the vessel is can dilate bigger? Because with this, if you go for bifurcation stent, you will just put a lot of metal around, the blood will be flowing around there, and it may not yield a very wonderful result. So the least I think we can, I also support here is provisional stenting for this, because the vessel is not that very big vessel to take a number of maneuvers.
Exactly. So
yes, Dr. Ibrahim and Dr. Tayo.
Yes, we clearly use every time Risordon to before PCI and when we perform our daily coronary angiogram. So this is the result after we inject before the stenting. We do heparin and then we inject Risordon, dinidrate isosorbate. So we go for provisional stenting, as most of you think. So from the proximal part to the distal one, we choose a 2.5 by 44 drug-eluting stent Ultimaster, inflated at 14 atmosphere. So, and then we take a 2.0 by 20 NC balloon to perform several post-dilatation and a good pot at the proximal part of the stent. So this is how it looks at the result. I don't know if you have any comment. So
yeah, I think this is wonderful, and going in whenever we see a bifurcation case, we're always worried about losing branches. Yeah. But, many of them hold up, it's just, we always fear the worst and take these extra precautions. But again, I think if I went to the trouble of putting a wire there, I probably would have ballooned just the origin to be a bit on the safe side. Especially if you're going to take out the wire before you stent it. And I see you did that. I think that's also a good thing to do, because that would have been a long amount of wire to trap, and you could run the risk of, trapping the wire. Yeah. So right. But I think this was very well done, and it's the only other thing I would say is it's important, that the patient was well anticoagulated, wasn't any platelets coming in, because sometimes if you're doing a case like this in an acute MI, there's a lot of thrombus, and you have a higher risk of losing these branches from thrombus. So the fact that there was a few days of pre-treatment also probably helped with this result.
Thank you. So, yes.
Just a comment. Very nice final result. Anything to say? But
thank you.
Why did you stop there? Why did you don't try to do a port side port or a kissing final to open the stress? The result is very good, and I think that. But just to know why.
I think the side branch is well, so it is open. So I don't need to go to try to cross against and struts to put a balloon there. And then I think the circ here is a small branch. So I have free flow in the circs, so I didn't. That's why I just stop here to go for further post dilatation, just to well oppose my stent.
Because when we look at here, there is a type not very critical. The TIMI flow is free, obviously, truly. Yes, Well, you're right.
Thank you. So we go to on the right when you see the proximal LAD severe stenosis. Again, we didn't have IVUS, but we decided to, after discussion, to stent this area of the LAD. So I don't know if most of you can go to stenting direct or going to perform another test. What do you think? Just if you have any one comment for.
Yeah, if I can again. So obviously, I do agree with trying, for complete revascularization,
Yes,
post-MI. I think there is clinical benefit there, but we
yes,
always have to consider risk with going after
yes,
another vessel. And, this is certainly the proximal AD. I think there's a diagonal that's coming out in this lesion.
yes, exactly.
So there's some risk again that has to be calculated. Um, and as the comment was made earlier, we don't want to lose branches and cause more trouble. So I would also want to wire this diagonal, pre-dilate, and then probably do another provisional. But I think just the main point is just to estimate the risk again before going
Yes.
to the next vessel.
Okay, thank you. So we keep it simple, just perform pre-dilatation, and we put a 3.0 by 18 millimeter Onyx 2-course stent inflated at 14 atmosphere. So, and this is the final result, the cranial. So this is the result. So the patient, when clinically stable, she have no angina, she was good, and was discharged the next day. So 6 months later, so she was good, no history, no problems. And 6 months later, the patient was readmitted for high-risk anasthenia with severe angina, EKG changes, inverted T waves in V4, 5, and 6, and high troponin. The grade score was higher. So in this case, where do you expect the cripples lesion? The LAD outside the stent, within the stent, or the OM, or another vessel? I don't know, any comment here?
You look like Lotto.
Professor Sharif, I know.
But you must tell us what we will win if we choose if we have the right answer.
The right answer. There is no.
It can be any of the vessels.
All the answers are good. They're all good. There's no wrong answer.
For me, I am outside the stand.
Exactly. I think also. In my mind, before I go to the cath lab, I say, okay, this is the OM, long stand, and I begin to think about the possibilities. I think so. I'm going to maybe stent it with a drug cotton balloon. So we went to the cath lab, and this is the first injection. So as you see, the OM is good, but we have seen something in the proximal part of the LAD stent. Yes.
And it appears proximal to the stent.
Exactly.
Yeah.
Exactly. So the stent.
So it's the LED.
So it is the LAD. So you lose.
Yeah, more to the stent.
I lose.
This is one of the risks of diffuse disease.
Yes.
Is during the initial intervention, there can be injury to the margins of the stent with balloon, and so this is not unusual.
Yes.
And it is why we sometimes err on longer stents to cover,
Yes.
any sites that are injured.
Exactly.
But I'm glad she got to you on time because this is critical disease. This is probably worse off than her initial STEMI, and she was definitely at high risk.
Exactly. So how can we best characterize this lesion angiographically? Because we didn't have IVUS or OCT, is that visually, angiographically, in stent restenosis within the stent, stenosis or proximal to the stent, outside the stent, or proximal edge restenosis or stent thrombosis. So I don't think if it has, it should be mentioned, the patient reported a temporary interruption of clopidogrel for a few weeks, 3 months after discharge. So for me, for one moment, I begin to discuss, to think if it is in the stent, inside the stent, outside the stent. So it was really a moment of discussion with colleagues. So I don't know what you think.
It looks like
it looks more like the proximal edge.
Yes, proximal edge of the stent too.
Yes, exactly.
I agree with the proximal edge of the stent.
Exactly. So I think it is also the proximal edge of the stent. So okay, yes. So a stent restenosis had been defined as a reduce of more than 50% of the lumen diameter within the previous stent segment or the vessel. 5 millimeter proximal and distal to the stent, or the stent edge. That's what helped me, this definition, the 5 millimeter just close to the stent. So the Meehan classification give us 4 main groups, and I think our case, it is focal, so type 1, and in the proximal edge, so type 1B. So what is the mechanism in our case? Is that mismatch, undersizing, underexpanding, neoantimal hyperplasia, neoarteriosclerosis, or residual plaque burden, geographic miss, or we can also discuss other features, osteal lesions, she's diabetics, femoral sex, and then anti-prophylactic drug resistance. So in this case, what should be clearly the cause of this stent intrastent stenosis? I don't know what you think, Professor Emmanuel. Is that under expansion or any comment?
Well,
these tend to be.
So,
go ahead, please.
Yes.
So residual plaque burden will be high here
Yes.
because, it's a diffuse disease. So
Exactly.
we pick a point and we expanded the stent on that point. So
Exactly.
residual plaque disease proximal to the point of the edge of that stent can accelerate this kind of atherosclerosis. But I still want to ask, do you have ticagrelor in Miami, sir? All your patients take aspirin and clopidogrel?
Yes, unfortunately, no. Sometimes they bring us few, packets, but
sometimes,
it finished.
yes.
So,
okay.
Yes, sometimes, yes. So in this case, exactly, it is it can be benefit for this kind of patient. So
yeah, I was
for
just
this,
sorry, I was just going to add that, yes, while I agree with residual plaque burden, I think these are usually a combination of factors, including the fact that she has diabetes. There may have been some slight geographic miss during the stent implant. So female sex, again, with diabetes, some drug resistance. So it's a combination of factors that usually lead to this type of event. I was going to ask if we know about her diabetes control and also how her lipids are controlled.
Yes. Yes, in the first slide, I show it. The diabetes is well controlled. The glycated hemoglobin is at 6.2%. And yes, the lipid 0.5 for the LDL. All cholesterol is good. So her biological findings are good. So I think this is, as you say, a combination of many factors, when 6 or 7 factors that lead to this in-stent restenosis. Without IVs, it is not easier. So this is, I think, in this case, intravascular imaging can overcome some of the diagnostic limitation of angiography and provide a help of further information to define and classify the in-stent restenosis. More acute assessment of the degree of in-stent restenosis, but also can appropriate identification of the underlying pathophysiological mechanism. So it is recommended class 2A or level B for the ASA, the European Society, and level C for the American Society. So what is the management in this case? So before choosing drug-eluting stent or drug-coated balloon, we have many devices: balloon angioplasty, ketone balloon, rotational, ELCA. So in our case, clearly we are in this range because the mechanism is neo-antimal hyperplasia or neo-atherosclerosis, or maybe I don't think so, DS under expansion. So we should prepare the lesion with high pressure balloon and then repeat DS, so implanted another stent or drug-coated balloon. So that's what we do. We perform high pressure balloon angioplasty on the proximal edge, and we have discussion. There is a landing zone, but we discuss if we are going to stent the left main or not. So I don't know if you have comments for this decision. Are you going to stent the left main or just put the stent? Yes.
For me, I think no, you don't need to stand the left main, but I think that you need to put a wire in the circumflex, to have 2 wires. Despite that, you are going to don't stand, but in case of we don't know, we never know. But I put a second wire to the circumflex, but I will stand. I will not stand the left main.
Okay. So I don't understand. If you are going to stand just the proximal part, why we put the second wire in this circumflex? It's just for support to have
for security, but sometimes you don't need, you go to stand only the LAD, but sometimes your stand sometimes your stand go out to the left main, and you may have an occlusion of the circumflex, and that's why to protect.
Yes. Okay. Thank you.
Yes, I agree as well that there should be a good landing zone here. You may have to go to steeper angles to open up the bifurcation better, but I would, yes, try to avoid stenting across this large circumflex, because that also puts her at risk for the problems down the road.
Thank you. So that's what we've done. We try to go on this landing zone with a 3.0 by 15 millimeter DS onyx true core, and flatted several times at 25 atmospheres, the medium part, the proximal part, and then the overlap area. This is the final result. So we took time to look at the result to see if we can go again with a 3.5 NC balloon, but I think diffuse disease, small woman, I think we stop there. I don't know if you have any comment, if someone...
Did you use stent boots or stent V's to see that
yes.
your overlapping and your stent are very open? It's sometimes you don't have IVs, but it can give you
exactly
a very good answer.
Idea, yes. We use daily in our daily practice stent V's. So prevention, I think, is the key. So careful lesion preparation is mandatory. Do not underestimate the plaque burden. So I think it is our case. Cover the disease, not only the stenosis. That's why we perform on the OM to cover all the lesion, and optimal stent expansion and POT when needed. So DL antiplatelet therapy adherence must be actively verified. The secondary prevention, aggressive control of cardiac risk factor, coronary disease risk factor is essential. So in conclusion, I can say that despite the recent advances in PCI, in-stent restenosis remain a significant issue and the most common cause of stent failure, accounting for 5 to 10% of all PCI procedures in modern clinical practice. Current evidence suggests that drug-eluting stents or drug-coated balloon are the optimal treatment modalities for the majority of in-stent restenosis cases. The intravascular imaging can provide useful information to guide treatment decisions. So a durable PCI result requires thinking beyond the stent, understanding the underlying mechanism of failure to guide revascularization strategy. Stenting does not always provide a definitive solution. At times, it simply replaces one problem with another. Thank you.
Thank you very much.
Yeah, thank you as well. This was very well done. If we had a surgeon on the call, I'm sure I'm sure they would have asked,
Yes.
why did you not consider CABG? He had multivessel disease, including proximal LAD, when you did your initial angiogram. So tell us why that was never considered.
Well, thank you. This is an excellent question. So this is when you see three-vessel disease, you see the LAD have a diffuse disease, the proximal part. There is also a plaque on the middle part, as well as the OM, and the right coronary is a small vessel with diffuse, no significant disease. So the syntax score that we use in our daily practice was intermediate. So we have to choose in this case for CABG or stenting. Clearly, our patient here, even the syntax score is higher, don't agree on, don't need to go to surgery. They don't accept because it is very expensive. It is sometimes at high risk. So in our syntax score, as we say, sometimes we should consider the level or the experience of the center, of the surgical center. So that's why in this case, the OM is the culprit lesion. So we go first for culprit only strategy. And when we finish quickly, we then turn to the LAD. I don't know if I answer your question.
Yeah, wonderful. We would have treated her just like you did. So, but those were great comments you made.
Thank you.
Okay. Just a comment about one of your conclusion and treat the disease and not the lesion. And I think that in daily practice, it's very, very difficult, despite that you have IVs and you know what is the landing of the longer of the lesion, because the longer of the stent and you have more time to have more risk to have restenosis, to have thrombosis, as you know. And sometimes, and it is to choose the balance between treating only the lesion or treating all the disease. And as you see here, when you stop sometime in the plaque, you have risk of restenosis or other things. And when you put a longer stent, you increase the risk of thrombosis. And it's very, very difficult to choose to choose the devils.
Yes. No, you're right, Professor Sherif. That's in some cases, yes, when the stenosis is clear and the disease in the proximal part is not clear. So sometimes we don't we leave it alone. Generally, when the disease in the distal part, I didn't stent it. Yes, but when it is, I have a plaque on the proximal part, and that plaque is not far from the lesion, I prefer to cover the plaque and well upon the stent.
Okay, thank you.
Thank you, Professor Sharif. So I don't know if Emmanuel is here to introduce, if the moderator or some comments. The next Iseko is here.
Yes, thank you.
Yeah, so my comment, yeah,
Okay.
Dr. Ibrahim, very wonderful.
Yeah, thank you, Emmanuel.
Yes, I'm here. Very wonderful case. Can you hear me?
Yes, I can hear. I'm getting you.
Can you hear me? Good.
Yes, we are hearing you, Emmanuel.
We're hearing
Go
you
ahead.
loud and clear.
Yeah. Yeah, I said this is a very great case, very wonderful case.
Thank you.
Excellent.
Thank you.
I want to ask, yeah, and before Dr. Iseko start, I want to ask, knowing very well this patient is 57, she's diabetic, also hypertensive, dyslipidemia. What will be the duration of your dual antiplatelet? How long will you go for this type of case, knowing very well here that the patient had very long stents in the sec, and another two stents again in the LAD?
Yes. So this is an excellent question. Thank you, Emmanuel. And I think in this case, when you see the management of N-stent restenosis, they recommended to go more than 1 year. So in this case, clearly, we are going to maintain for 1 year and a few months, and we are going to see if the patient is symptomatic or not. Actually, the stent in the OM is a third generation stent, so it is a good stent. It is I'm not doing but I think it is a third generation stent. That's why probably it doesn't it will stay for a long time without thrombosis, I hope. But in the proximal LAD, you see the result is good, but I'm not so, I think this is there. I don't have eyes to see the left man, but I think this woman clearly is going to come back for the left man, but I don't know when. So I'm going to keep gel antiplatelet therapy for 1.5 years or 2 years.
That is fine.
Thank you. Thank you, Manuel.
Hi, everyone. A very
great,
good presentation. Just something I wanted to, plant a seed in your mind. Given how young this patient is, and the fact that she's already had 2 events, the interventions she's had so far are really good. Looking at her anatomy and the fact that she has diabetes, hyperlipidemia, and how young she is, I think looking in the future, I know this patient is most likely going to come back, and at some point, you're going to run out of real estate to lay stents. It would be a good thing for someone like this to start planting the seed in their mind that they may ultimately require a CABG in the future. It may not be the next intervention that she receives, but it will be something, to work on so that people psychologically start preparing themselves so that at the point where they do need the intervention, they may be more receptive to it.
Thank you. Thank you, Robert. I think this is a good
Very
point.
correct.
Yes. Well, I don't know if we have Emmanuel, you can introduce Iseko.
Yeah. So in the absence of any other question, I think we have to move to Dr. Iseko. Dr. Iseko, Iseko is a very good friend of mine, and we have been together for many years now. And he's the chief of interventional cardiology at CardioCare Multi-Specialty Hospital, and it's a complex interventionist, and he has performed many complex interventional procedure at the CardioCare Multi-Specialty Hospital. So it's a privilege to welcome Dr. Iseko, sir.
Thank you. Thank you for having me. I'm very happy to be here. Thank you, Dr. Edafe, my teacher, Dr. Professor Tayo. Thank you so much. I'll just be showing some case discussions, but because of the people from other countries here, I'll first give a short preview on as it relates to Nigeria, our findings over the 12-month review that we presented recently, looking at 12-month cases, just a few cases, 48 cases where we reviewed PCI and acute coronary syndrome in Abuja. Patients are predominantly male. Mean age in our cath lab has been about 55 years. LAD being the predominantly affected vessel, hypertension and diabetes being the most, and diabetes in almost half, and hypertension in 80%. These were the total patients, like we talked about, and unfortunately, almost all the patients came late. Over 88% of the patients came very late to the cath lab, already with some level of dysfunction, and sometimes some of them came because of the heart failure symptoms. Mean ejection fraction was 45.5%, and troponin median was 2.16. Late presentation was common, about 95%, greater than 24 hours. Only one patient received thrombolysis before PCI. In-hospital mortality of 2.1%. Mainly no reflow was seen in 17%. No intraprocedural or 30-day post-discharge deaths. Patients were younger, more male predominant than cohorts in certain registries around the world. Very high late presentation rates, and comorbidities were highly prevalent. And these findings emphasize a lot of gaps. So I'll just go straight into a case and then having looked at it. And just to say that multiple issues. First is the patient identifying the symptoms then whether they go to the hospital or not, or whether they go to a church or go to a pharmacy, and whether they are recognized to have an MI. So one of the work we have been doing is to educate first responders, then trust across people referring, then whether there's available interventional capacity, and one of the case we'll talk about will highlight that. Then we now come to financing. So most times people are trying to identify or solve the number 4 and 5, but there are many other bigger issues also in our environment. So a long journey looks straightforward, or is it? Pardon my French interpretation, but I think it's fair enough from AI. So acute STEMI or somewhat acute. All right. Again, my French. For 50-year-old professor, recurrent chest pain in the past, which was not evaluated, severe chest pain, 3 days, developed stroke with aphasia thereafter, transported by road from Sokoto to Abuja, over 9-hour journey by road. By the time he came in, he was in cardiogenic shock, pulmonary edema, ongoing chest pain. So what do we do from here? This was the coronary angiogram on coming in, and so I don't know if we have any discussion for this. He's had a stroke, cardiogenic. He's on, by the time we got him to the cath lab, he's on dual inotropes, and he's had some aphasia as well. 9-hour case, 9-hour on the road, and 3-day post-MI. Okay, I don't know if anybody has any.
Yeah, Dr. Iseko, the EKG and the ECG, how did they look like?
I'm so sorry. I don't have the EKG. But the EKG was essentially lateral leads that had more of the
Okay.
elevation, but it was getting more almost Q wave like at the time he was reaching.
Okay.
Yeah, again,
Okay.
question will
What of
be,
the echo? Was there any?
So the echo just showed some regional wall motion abnormality, and the ejection fraction was about 35 to 40% as the time he was coming in. But the main thing we're looking for was intramural thrombi, which we did not see, or any aneurysm, being that he presented with a stroke,
Yeah.
was not available, was not there.
so again, I'm curious about what he got
Because
at
the
first
the
medical
sec is
contact.
totally occluded.
So the first medical contact, no thrombolysis done. He had dual antiplatelets. It was a teaching hospital, and that was just about it. Then he developed a stroke. He was not on anticoagulation by the time he came in. Of course, I think they were in a dire strait. They did a cranial CT, which revealed that it was ischemic and not hemorrhagic. But then at that point in time, they just referred and then put him on the road and then called us ahead that he was coming. So that was about what he had. Statins as well, just general medical therapy, but no anticoagulants and no prior thrombolysis.
But in general, there's availability of anticoagulants, is that right? Can patients get Lovenox or oral anticoagulation routinely from where he's coming from?
Yes, anticoagulation is routinely available everywhere in Nigeria. Clexane, enoxaparin, that's enoxaparin generic. Apixaban, rivaroxaban, that's Eliquis, or I don't know what the other one is in America, but it's Xarelto. So it's quite available. It's quite accessible in terms of financing, so it's not too costly. So yes, it's available. But I think the fear of in between the ischemic stroke and all of that was a problem, and that is likely why he was not placed on anything at the time.
Yeah, again, I'm sure the whole group knows this, but even in the absence of thrombolytics, the anticoagulation is indicated, may help ultimately restore some patency, reduce thrombus burden, because if this guy is showing up 3 days later and you have an occluded artery like this, the material in here can be very difficult to work with.
Exactly.
I think this is really very complicated cases, because when you have acute ischemic stroke, generally the first CT angio shows ischemic, but sometimes when you repeated the scan, in most of cases you have hemorrhagic transformation. So before going to the cath lab, I think for me it will be very important to know if this ischemic stroke is not going to have a secondary hemorrhagic transformation. So that's the first. The second thing, I don't know if you have any drug support before going to the cath lab. How is the vital parameters, like the tension, the blood pressure?
Okay, so we had considered all of that, but as at this time, pulmonary edema, cardiogenic shock, blood pressure, he was on dual inotropes, dopamine and noradrenaline, and blood pressure at about 105/50 as at the time we're entering on the dual inotropes. We had considered putting an intraortic balloon pump, but our IABP was unavailable at the time, A, and B, the prolonged anticoagulation and the extra anticoagulation that may be needed with the IABP was something we consider, but the IABP was not available anyway, so that was a no-no for us. So we had to just use what was available, which was 2 inotropes to take on the case.
The patient is intubated?
No. Patient is conscious. Initial furosemide and morphine had helped the pulmonary edema. So we had to wait about 4 to 6 hours to get that under control. he was better. Was able to lie down with one pillow, at least two pillows, for us to do the case.
Exactly.
Yeah.
Yeah, this is why this kind of cases. So they can't go to the cath lab because if they're not intubated, they have severe pulmonary edema. I don't know how they can lay on the table. It is very complicated. So if they're not intubated,
so the way we normally approach it is for us here, the patient is coming in late. If they are too sick, then we get the anesthesia to intubate them. Otherwise, we give the anesthesia on standby. We try and use medical therapy, a combination of nitrates, if the blood pressure can take it, furosemide, morphine. Once we're able to get them to lie on one or two pillows, then we are forced down to radial access. Sometimes we prefer femoral access. I know you prefer radial access.
yes.
Then you try and get that in, and then we'll do the case. That's what we have largely done, for a while now. And that has been fair enough. Or sometimes, since they are coming late, we may delay by up to 12, 24 hours to get them more stable, thoroughly anticoagulated, before we take them in. And that often gives us at least a lot better. Get some recanalization, reduce the risk of no reflow, and all of that.
Thank you.
Okay, so I'm sure we can all make out the circumflex total occlusion. And also, I will show you something that went ahead now. Okay, this was the RCA, diffuse disease. We can see across the RCA. Same thing, circumflex, I won't say it was a clean vessel, and diffuse disease from mid zone all the way down, but our concern was mainly on that. So, to get the wires down this vessel was extremely difficult. So we had to use different wires to approach it. And you can see there's a second wire there. So almost had to do a seesaw method, then use a balloon, a microcatheter there to help us cross it. And then we finally were able to cross the lesion. Then we ballooned the lesion 2.0 balloon. This was the initial wire, which should be going out now. And they were able to see some good flow thereafter. But you will notice that there is an almost double bend, which was not very apparent to us at this point in time. There was a bend that comes towards us and then goes down. So by the time we did this, unfortunately, with all of this, the stent will not cross. The second wire was passed on as a body wire, but still the stent will not cross. So at that point in time, we brought in a guide extension, a guide extension with an anchor balloon, and used the balloon to anchor while we advance the guide liner slowly across that bend. And then, as you can see, it's advancing. Then, having advanced, then we could now pass the stent relatively easier, and then pull back the guide liner. And this was the shot thereafter. You use a 3.0 stent, and this was the final shot thereafter. Patient did very well. Need to say, no worsening of neurological complications, which was our major fear, with all the heparin during the procedure. So by the next day, he went off the inotropes, blood pressure appreciated, managed in the ICU, and continued physiotherapy, and did very well generally subsequently. I don't know if there are any questions or queries.
It is a very great case. Congratulations. I think it is a very good result. So I don't know how you use your guide liner. Did you put a small balloon when you push the guide liner, or you just put it alone?
So we put a small balloon. We put this balloon here to pin the wire in, and then we pushed it across over that. We had considered inch warming it, just putting the balloon, deflating and moving over the balloon. But on second thought, this was easier and more straightforward. So put a balloon here. That's the balloon that is inflated there at nominal
For the
pressure.
anchoring.
Anchoring, yes, at nominal pressure.
Mm.
And then we now inflated that. We now went ahead with that.
Because sometimes if you push like that, sometimes
Yeah.
yes, it can, yes, you know. So the guideliner may create dissection. So this is why you
Exactly.
put a small balloon, and when you withdraw the
No,
balloon and you push yes to advance.
So we know that there are different
no.
techniques to
See,
introducing the
what you
guideliner.
can do, I think what Dr. Iseko is trying to explain. Dr. Iseko, can you explain it again, that techniques?
So there are different techniques of introducing the guideliner. One of the techniques which is commonly used is the inchworming. That is to put a balloon halfway in, halfway out, and then as you deflate, you push it forward. It will help reduce the risk of dissection.
Yes.
But you could also use the anchor balloon technique. Take the balloon distally down the wire, inflate it, and then it kind of pins down the wire, and you pin down the wire, and then you take it over the rail in a very guided fashion. And that's what we used here, this anchoring balloon technique, and which went very well with no issues. But I do understand one of the big fears is the dissection if you just push it in directly over the wire without anchoring or without doing the inchworming technique. I don't know if there are other techniques, but those are the two techniques that I'm more familiar with.
So here the anchoring is to guide the
Yeah,
guideliner, not for stability, not for to keep the. So it's just for the guideliner.
Yeah.
The anchoring. Okay.
Yes.
Thank you.
yes. Then another thing I still want to explain in this case is that when you inflate the balloon, you do this, this one I want to describe, you do it on fluoro. You inflate the balloon to standard, that is the nominal, then while on fluoro, hold the end of that balloon so that it gives you a straight anchor, and you now push the guideliner while you hold the balloon so that the wire and the balloon does not
Move forward.
keep down while the guideliner goes. You have to put some pressure, some strength on the balloon so that when you push the guideliner slides on top of them while you wash it. So that the wire and the balloon don't gape down to injure the wall of the vessel. That is when this technique is very important. If you know how to do it, it's very simple and straightforward. It can help you to navigate a lot of tortuosity of vessels when you encounter them.
Right. Yeah, no, this has been really great, and again, wonderful final results. I believe I noticed during the angiogram that there was mid-LAD disease. If you're able
Yes.
to show that again. And I think the patient probably got very sick because, the patient has multi-vessel disease. So I was curious if you thought about the LAD disease, about treating it, and about timing of treating the LAD.
So we thought about treating it, but not at this sitting because it was in cardiogenic shock. And then, we just put 2 pillows up, and to do this case, blood pressure was barely hanging in there, and we did not have any intra-aortic balloon pump support. So as soon as we got the circumflex in, and we just came out and decided to come back again. But subsequently, after a couple of days, all the clinical symptoms got better, chest pain down, troponin on the downward trend, hemodynamics much, much better. We said, okay, we'll give this another time to come back in. We did not feel, even though it looks critical, we felt that drug therapy for now, because landing zone will be a problem, and then it looks quite diffuse, even though the main place is here, and here it looks quite diffuse all the way down. So for now, I left it, and then with the stroke, I just felt that we should leave it for some time, come back in 3 to 6 months, reassess again, and then decide whether to go on.
Dr. Iseko, great case.
Oh,
This is
I
Dr.
still have a question.
Dr.
Okay.
Tayo, okay, go ahead.
Sorry, this is Dr. Kushima speaking. I wanted to ask, how is the right?
The
The RCA, I'm fine. How is the right? How was the RCA?
So the RCA I showed before, that's the RCA, also diffuse disease. This is a patient that if he comes again with any other concurrent angina, we'll definitely have to consider coronary artery bypass grafting as an option, because the right also has this diffuse disease across.
Yeah, I was just
will you have treated that LAD?
Now, I have this question for Dr.
Yeah, so yeah, I was just gonna say, I completely agree with the way you managed this case. And again, congratulations. You know, for this very sick patient is to focus on the culprit and also hemodynamic recovery. And you know, you were able to do this even without a balloon pump, which is you know, very impressive. And yes, I would have waited and defer the LAD to the outpatient setting. And you know, again, weeks down the road, that can be considered, but this was absolutely the way to handle this case. The last thing I was just going to bring up was the antiplatelet therapy. And you know, I don't know what the availability of ticagrelor is, but I think for a patient like this, a more potent agent is going to be very important. This territory is infarcted. There's going to be a higher risk of thrombosis, and I think a more potent agent like ticagrelor will give you better outcomes.
So yes, that will be very good. We have ticagrelor in Abuja, but it's not available in the other parts of the country except Abuja and Lagos. So sometimes I feel it is worse that they go off anything and have an instant thrombosis. So I typically leave them with what I'm sure that they'll be able to get in their environment. If they are well to do, then sometimes they can take a good load from us and then send ahead of time via DHL, FedEx or the like across states. But otherwise, sometimes it's just too much of a risk to give them a drug that they may not find in their locality. So ticagrelor is available, but it's mainly in Lagos and Abuja. Most other states do not have it readily available, and I'm not sure it's a risk that patients can go off their drugs. So that is why we don't really use it if they're not in Abuja. Hello, is somebody talking?
I think Emmanuel's connection is not, he tried to.
Yeah, very good case, Dr. Iseko. Congratulations. Excellent case. So now, here, first, I want to really congratulate you for this very beautiful case. The demonstrations of the techniques for the guideliner, how to pass it without injuring the vessel, especially tortuosity of vessels or various curves within the vessels or angulations that make it difficult for your stents or balloons or wires to pass through. These are some of the things we do face here. The resources in Africa, especially in the sub-Saharan Africa, are really very limited. And we don't have all the accessories that Dr. Tayo has access to in the US. We don't have that here. So the little we have is what we use to make sense out of it. So like the case, Dr.
I think we have lost Dr. Edafe. I think we have lost Dr. Edafe.
Yeah, it appears so, but maybe you can continue to fill in. How do you manage resources? I'm not sure this patient could have afforded all of these items. How do you go about, providing this level of, care when resources are very limited? So if you can give us some perspectives on how you do it.
So it's normally multi-pronged. Occasionally, we have some relatively richer patients, but a lot of times we have one or two donations from the Cardiovascular Education Foundation, which are a part of, and that really helps us to spread and to make sure that these are covered for this kind of patients, so that we don't have to look over our shoulders. So that has been the mainstay, really. The donations that we get allows us to be able to use microcatheters, use multiple wires for this kind of patients. Otherwise, sometimes we use it, we run at a loss, and some other patients might come in that may be more well-to-do, and we might be able to make sure that that covers for the other patients. So that's essentially how we've been able to manage resources. In the study that we did a study on financing of patients in acute coronary syndrome for the same group of patients. About 8% of patients were covered by insurance, typically high-end private insurance and their companies. The remaining 90% were out of pocket. So yes, it's a challenge. And from the studies that we did, those are the patients that could afford. Some patients could not even get the procedure at all to an extent. So that has been a major challenge here, definitely.
Does Dr. Ibrahim have some comments?
Yes,
What's
yes,
the situation like in Niger?
Or in
yes,
Dakar?
it is. I think we have the same situation. So for the accessories like guideliner or microcatheter. So I don't know if you use only once for the patient, or you can use it again. I don't know, Iseko, what you do in your daily practice. This kind of devices which are not available and expensive. So if the patient is going to pay for these devices, or if you are going to reuse for the next patient, I don't know how you do. So it
Unfortunately,
is
we
really difficult.
use only for once and we discard. But we've purchased a plasma sterilizer. That is a cold sterilizer that may allow us to use it again. But for now, we are still using for one patient, everything one per patient. And yes, it's expensive,
Yes,
but I mean, there was no way to have delivered these things without a guideliner and multiple wires, or even got the wire pass without the microcatheter and all of that. So a lot of times, rather than use microcatheter, we'll use an over-the-wire balloon in place of a microcatheter.
yes,
So we find a way to do that. But a lot of times it's one patient and that's all. But now we are able to get plasma sterilization. So hopefully we will be able to defray the cost across multiple people and reduce the cost for them.
exactly. Yes, I think it will be the future, because in Europe they are trying many studies to see if they can. That's why we talk about in Dakar, if you remember, the sterilization of the material in our countries. I think it can really help patients. So we have many cases of acute coronary syndrome, and they can't pay. So sometimes we do what we can.
What happened in Nigeria?
Yes.
Okay, Dr. Ibrahim is talking.
Yes. I say we have many
Yeah,
cases
what
of
happened in Nigeria
Yes.
is
Yeah, go
similar
ahead.
to what also happened in other parts of West and Central Africa. One thing is that most of the patients pay out of their pocket.
Exactly.
Same thing we have in Nigeria, the same thing you have in Senegal, the same thing you have in Miami.
Yes.
Then also, the time to presentation is also most time is also late. A patient may even have STEMI in Abuja. The patient will first of all travel to Kano before returning from Kano back to Abuja again for the same thing that started in Abuja. So there are issues. So as there was a slide that Dr. Iseko showed here that is very important, that is a slide of talk about the financing, education to the patient relative, the society, the policymaker, and everybody, even not just only the non-doctors, educating there's a slide you showed, Dr. Iseko, very important slide. Yeah, this is the slide. Yeah, education of the patient, and also educating the society is a big problem. Also educating the medical doctor to refer the patient on time. Yes. It's a very big problem in our environment. I don't know how you see it in Miami, but in Nigeria, it's a very big problem. Because when a patient gets this STEMI, the first thing the patient will call is his relation, either her husband or her wife or her brother, his sister, and the rest. So it's the guardian that will first come from there that will make the patient go to the right source. If the guardian from that point of the first call is wrong, the patient will go through 10 hospitals before he finally gets to you if he's still alive. Yes. These are the cases I see here in Port Harcourt. It's the same thing in Lagos, the same thing in Abuja, the same thing in Miami, the same thing in Dakar. It's all spread around like that. So we have a lot of work to do in order to get the timing from symptom to intervention, especially the Black patient in their native land. When I say the Black patients, Nigerians that are...
I think he's falling out.
Yes, network, Iseko.
Yeah, Dr. Ibrahim, you were saying what was happening in Miami when your patients don't have...
In Miami, exactly what Iseko is, what Emmanuel is saying, it is the same problem. So, you know, the patient that comes in our cath labs, they do many hospitals before they come. And at the early stage, at the beginning of the symptoms, sometimes even when the doctor tells them that they have something very serious, they don't really want to, I think, sometimes pay. So they stay home or in the hospital until they become very complicated. When cardiogenic shock and then pulmonary edema, and then they bring them at this stage. So at this stage, unfortunately, it is very complicated because when we keep the patient in the hospital, he can stay sometimes for 1 week and 10 days before you to take him to the cath lab. It's not easy to take someone with pulmonary edema in the cath lab. So if they have chest pain, we can discuss with the anesthetist to see how we can manage. But if there is no chest pain, it is complicated for the late presentation to take a patient to the cath lab, I don't know, 1 week or 10 days after a myocardial infarction.
So thank you very much. Thank you for sharing your experience. Professor Kane is in. Professor Kane, welcome, sir.
Thank you so much. I'm sorry, I just landed now. Sorry.
Welcome, Professor Kane. Welcome.
Welcome.
Thank you so much.
I was more Morocco.
It was very cold and the
yes, it's very cold.
Yes.
I am in my first comment. I congratulate the Senegal team for the first TAVI cases.
Yes.
Yes.
Dr. Tayo, they just did their first TAVI cases in Senegal.
I don't know if
wonderful.
It was done by the military hospital of Professor Booth and his team, and for us it's a good advance and for sure nice perspectives for Senegal, and I hope that we will go through for all the sub-region.
Awesome. Okay, I think
big congratulations. And again, this is wonderful, this first session, and I'm not sure if Dr. Dafe will be able to join us again, but I just want to congratulate everyone on putting this together.
I'm back, sir.
Okay, let me. I'll turn it over to you. But
I'm back.
yes, please. I guess we must be coming to the end here. But
Yes,
really enjoyed this session today.
Thank you very much, sir. We are very happy to have you.
Emmanuel, Professor Khan is here.
Yes, because it was just to apologize and to say hi to everybody. I know that we are at the end. I just learned now. And thanks again for this initiative.
Thank you.
Yeah.
All right. Thank you very much,
beautiful.
everybody.
Is it Professor Abdul?
Yes. He just landed.
Our professor is here.
Very good.
Thank you.
Yeah, you just great.
Yes.
Oh, very good, Professor Abdul. You're welcome. You missed today. So this is the second our second Zoom meeting. The next one will be 2026 in January, God willing. I want to thank Professor Abdul, Professor Tayo, Dr. Iseko, Dr. Ibrahim, Dr. James, everybody.
I think today I think Emmanuel's network is not at its high level. It's not at its high level, so I think we can.
Yeah, so thank you, everybody. We're so grateful. Professor Tayo, Professor Kane, and Dr. Edafe, Dr. Kushimo, thank you for joining us. Dr. Ekwebo, we are so grateful for this. So our next meeting will be in January by God's grace. And then we will hope to get, but the whole idea is to get the Francophone, the Anglophone together, sharing experiences. And then, of course, we'll link up with the Cardiovascular Education Foundation and make it really big across the whole West African sub-region. We believe that we have a lot to learn from each other and a lot to share, even despite the Francophone and Anglophone differences, but there's a lot to share, a lot in common, and we can overcome these challenges together and learn from each other so that we don't make the same mistakes. So thank you very much. God bless you. Have a lovely evening. I'll be ending the recording now, and hope to see you in the new year. Happy New Year ahead of time.
Happy New Year.